Welcome, friends. It is our great pleasure to introduce you to SICOT Pioneer. Pioneer is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
A very good morning, good afternoon, and good evening, ladies and gents. I'm Vikas Kanduja, consultant orthopedic surgeon in Cambridge, UK, and one of the founders of SICOT Pioneer. And it is indeed a pleasure to welcome all of you logging in from different parts of the world to this webinar. Now, in the COVID world of non-contact domains, we've certainly embraced digital competitiveness with the launch of SICOT Pioneer. And through this platform, we've done over 50 events and have now had over 80,000 views from 110 countries around the world. So a big thank you for joining in and following us. We are certainly looking forward to our Congress in Kuala Lumpur. And as a prelude to that, we've got this Twin Tower webinars. On the other channel, we've got hip arthroplasty and trauma. And on this channel, we've got the Hindfoot deformity. A big thank you to TM from Hong Kong for taking the lead in organizing this. And a big thank you to all the gurus in foot and ankle surgery from the whole of the Asia Pacific who've given up their time to actually come and teach on this webinar. Big thank you to all of you. Without much further ado, I'm going to hand it over to TM. But prior to that, we've tried to make this as interactive as possible. So please do post in your questions. And if you can't join us today, then you can access the webinar on our educational platform. So over to you, TM. And a big thank you again to all our speakers for giving up their time for this webinar. Thank you.
Oh, okay. Thank you, Vikas. And good morning, good evening, good afternoon to all our speakers and participants. Welcome all of you to join the webinar, Hindfoot deformity. So before our section start, may I introduce our speaker today. Our speaker is Kim Wei Chong from Singapore, and he is going to talk about the biomechanics realignment in Hindfoot. And we have another speaker from Korea, Professor Jin-Boo Lee, who will talk about the ankle replacement. And we have another speaker from India, Rajaj Simon, and he was going to talk about the fusion. Last but not least, and we have Andrew Stephen from Australia. He will illustrate he will give us a case discussion, and I'm sure that today this section is very fruitful. And without further delay, may I invite our first speaker, Kim Wai, my old friends, okay, to talk about the biomechanical realignment in Hindfoot.
Thank you. Thank you. Okay, I'm going to share screen now. Okay, can everyone see my screen? Okay, thank you, and a good morning or good afternoon wherever you are from Singapore. My name is Chong Tin Wai, and I'm going to talk about the role of biomechanical alignment in the hindfoot and how it can change the natural history of hindfoot pathology. So, a brief introduction. I'm going to talk about a little bit about the role of alignment in joint damage, how to assess alignment objectively, and the common clinical presentation of malalignment in the hindfoot, which is often ankle varus and subtalar joint valgus, and how early realignment corrects the joint environment. So the hindfoot is actually very important. It is part of the mechanical axis, but it is often not noticed because all the residents are taught to draw this line through the hip, through the knee, and through the center of the ankle. But we can all see that the line stops at the ankle. It doesn't go beyond. So a lot of times, whatever deformities that happen below the talus is not, nobody pays attention to it often enough. So the role of alignment in joint damage is the same as the knee and the same as the hip in the hindfoot. It should be no different. All malalignment should be corrected and must be corrected. So we are all quite familiar with ankle joint realignment for treating early osteoarthritis. This is a concept that is quite well established. And the most common malalignment in the ankle is actually varus. So varus malalignment in the ankle, osteoarthritis in the ankle, would be most appropriately classified by the Takakura classification, whereby stage 1 is subchondral sclerosis, stage 2 is medial joint narrowing, stage 3 is bony contact between the talus and the medial malleolus, 3B is bony contact between the talus and the tibia, and stage 4 is complete joint narrowing. So once we are able to classify the various malalignment, then we can do something for it. So if we look at Tanaka's and Takakura's paper, we can see that a realignment of the deformity can improve the staging. So if you look at this lower tibial osteotomy for various type osteoarthritis of the ankle, you can see that there are many cases of 3B that improves to 2. There are many cases of 3A that improves to 1. Stage 2 improving to 1, and so on. So we can see that in general, correcting the deformity before the ankle reaches a stage 4 situation whereby ankle replacement or an ankle arthrodesis is needed can be effectively done and can have very good results and can even reverse the stage of disease. So these are some examples. This is supramalleolar osteotomy of a patient with Takakura stage 3A. And one can see that before surgery, there is bony contact between the medial malleolus and the talus. So this is 3A. And after surgery, you can see that there is opening of the joint space. So it has gone back to become a stage 2, whereby there is a mild narrowing of the joint space on the medial side, but there is a clear space that is created between the medial malleolus and the talus. So in this other example, we can see that there is a stage 2 that has improved to stage 1. So this is a 55-year-old female, and there is narrowing of the joint space on the medial side. So this is a stage 2, no bony contact yet. And if you look at her MRI, you can see kissing lesions. The whole medial surface has got bony changes. So this is not an osteochondral lesion. This is osteoarthritis. And intraoperatively, you can see loss of cartilage on the medial side of the talus. And again, after surgery, you can see a restoration of the joint space to stage 1 because it is evenly spaced. The gap is the same throughout. This is a patient with more advanced varus malalignment. This is a stage 3B where the dome of the talus is in contact with the tibia. So there's bony contact at the dome. And for this case, I did a supramalleolar osteotomy, the dome osteotomy. And one can arguably say that this has gone from 3B to maybe stage 2. But in general, the results of 3B realignment is not as good as 3A and below. So we are quite familiar with malalignment at the ankle. Now the bigger problem comes below the talus. And the common clinical situation is valgus. And we often dismiss such patients as having flexible flat feet. But actually what they have is peritalar instability. There is a lot of hindfoot instability around the talus that leads to a valgus malalignment. But the problem with malalignment below the talus, okay, hindfoot malalignment, is that it is very difficult to assess the subtalar and peritalar alignment accurately. So in the ankle, we can see that there is Takakura classification, which makes things very, very objective. If it is a stage 2, it is a stage 3, you can easily tell. And when you can stage it, you can plan treatment accordingly. But when the deformity is below the talus, it is very difficult to quantify. So both these patients you see are patients with hindfoot malalignment. But we can see that on the right side, it is more severe. On the left side, it is slightly less severe. But how do we quantify? How do we measure and decide that this is severe, this is moderate, or this is mild? Because before we can do that, we can't institute appropriate treatment. So the current X-ray assessment of hindfoot alignment is in either one of these forms, often commonly called the Saltzman view. The problem with this view, this radiological view, is that the calcaneum is an irregular shaped bone. And having to measure the alignment of the calcaneum is actually very difficult because it's very difficult to draw a line through the calcaneum because the calcaneum is a very strangely shaped bone. It's easy to draw the axis of the tibia and the axis of the fibula, but it is very difficult to draw a line through the axis of the calcaneum. Moreover, the rotation of the leg during the X-ray affects the Saltzman view. And if you read the description of the Saltzman view, it says to try to align the X-ray to the medial border of the foot. However, we know that in patients with flat feet, they have an abducted foot. So the medial border is not in the right position. And some of them, and if we align them to the second metatarsal axis, again, there are patients with splayed foot, with metatarsal adductors. So the rotation is not accurate. So the rotation affects the view. So if you look at this X-ray of the Saltzman view of this patient, and it's supposed to be a pretty well taken Saltzman view, but you can see that the rotation is different. On the right side, you can see an almost mortise view of the ankle, but on the left side, it is an AP view of the ankle. So is this alignment, therefore, accurate? Can we rely on it to make clinical decisions? We can't. So the problem with current hindfoot alignment, hindfoot imaging for alignment, is that if you cannot measure with precision, you cannot assess the severity and the outcome, and you cannot plan appropriate surgery. So if we want to do if we want to pay more attention to hindfoot alignment, we need a better system. So what I use is this concept of FACO, which stands for fibular axis calcaneal offset. It is my way of grading and assessing hindfoot alignment, especially valgus. So what I do is I will take a standing view of the ankle, mortise view. And in the Asian, the mortise view is about between 5 to 10 degrees, not as much as 10 to 15 degrees in the Caucasian population. Once you have this view, you draw a long axis. You draw a line through the long axis of the fibula, which is a very accurate line because the fibula is a very long and straight bone. And when the line goes down to the foot, you measure the amount of lateral wall of the calcaneum. You look at the lateral wall of the calcaneum, and you look at the offset between the line and the lateral wall of the calcaneum. And if this is between 4 to 8 millimeters, this is mild valgus. If it is more than 12 millimeters, it is severe valgus. And you can see these 3 X-rays, the degree of valgus is quite easily appreciated when you put them all together. So for anybody who is more interested in the details of this, of the way of doing the X-ray and how to measure using the FACO method, you can refer to this paper that I've written. Now, what happens to the hindfoot when there is valgus? There is lateral hindfoot impingement syndrome. This is something that is not often mentioned. And what happens is that the lateral process of the talus is impinging against the angle of descent, and it causes mechanical damage. There is also impingement between the talus and the tip of the fibula, and there is also mechanical damage. In addition to that, there is also people who has proposed this concept of vascular damage. So if there is severe hindfoot valgus and the lateral process is impinged against the angle of descent, it can close off a nutrient artery from the sinus tarsi that supplies the calcaneum. And then there is osteonecrosis, and then there is bone death, and it leads to a cystic formation, which we can see on and off when we do X-rays, and it is often reported as intraosseous ganglion, and we all think that it is harmless, but it is not harmless. So this is an example of a 16-year-old male patient with severe pes planus and hindfoot valgus, and you can see on the MRI that there is a large intraosseous cyst right below the angle of descent. And then you can see that there is an abnormal FACO, and there is also subfibular impingement. So the FACO is 11. Remember, less than 4 is normal. So his is 11. Now this is another patient with a cyst at the angle of descent. Again, it's just happening too often. FACO of 9, you can see that. And then there is a cyst right at the angle of descent. Flat foot, hindfoot valgus. 35-year-old female. These are young patients. The cyst has only just started to appear. These are older patients, 55-year-old, and you can start seeing bony damage, cystic changes, arthritic changes. This patient has a FACO of 12. This is a even older patient, and you can see extensive cystic changes and bone damage on the lateral side of the hindfoot. This is 50-year-old flexible flat feet with a fibular stress fracture caused by excessive lateral hindfoot impingement syndrome. So this is 11 months of non-healing stress fracture of the fibula with a FACO of 10. This patient has a lateral gutter cystic changes in the talus, and this is not OCD. This is actually caused by lateral hindfoot impingement, and this patient has a FACO of 12. And they are all symptomatic. So if you correct the hindfoot malalignment, you can prevent a lot of these from happening. If you correct it early, it often involves only probably endoscopic gastrocnemius recession, a minimally invasive subtalar stent, or you may call it arthroeresis, a minimally invasive medializing calcaneal osteotomy. Everything is done with a few holes. Why not? So endoscopic gastrocnemius recession is my go-to procedure for heel cord lengthening if the silver skull test is positive. And the subtalar arthroeresis using the hypocure to stabilize the peritalar joint is also a very favorite surgery of mine. And in particular, I would advise choosing a type 2 implant and not a type 1 implant. I have used everything from type 1 to type 2, and the type 1s are the ones that cause some degree of sinus tarsi pain and complication, and the type 2 has completely moved things away from having sinus tarsi pain and residual pain, and they do very, very well over the long term. So this is a minimally invasive medializing calcaneal osteotomy. You can do it with a burr, with an even smaller percutaneous incision. I still like to use drill holes and osteotomes, but again, even then, it's only a 1 centimeter hole, and you can do a MCO. So changing the natural history, how can we see that? So we go back to the 50-year-old with the non-healing stress fracture, 11-month-old phaco 10. And you can see that after 3 months of correcting the hindfoot alignment, the stress fracture has healed. And this is her phaco from pre-op to post-surgery, from 10, phaco of 10 to phaco of 2, and the stress fracture has healed in 3 months. This is the 16-year-old that we saw earlier with the cystic change at the angle of Visane, painful heel. And this is after endoscopic gastrocnemius release and hypocure. And you can see this is before and this is after. There is resolution of the marrow edema and the symptoms have resolved. So the natural history has changed. It will not go on to joint damage. This is again the same patient. This is before. You can see the cystic change in the bone, and this is after. This is hypocure. And this is after. You can see that the cystic change has completely resolved. So this patient, the same patient, this is his change in the phaco. And you can see how the alignment of the hindfoot changes. And you can see that the X-ray, the phaco, gives you a very nice visual impression of your improvement after surgery. This is the patient with the lateral gutter edema, which is not an OCL, okay, and it is actually impingement. This phaco is 12, and again after correction, you can see that this is post-surgery, 4 years after surgery. His phaco has changed from 12 to normal, 4 years post-op. And again, this is him, okay. No pain at all in the sinus tarsi. So the type 2 implants tend to do very well. So in conclusion, the hindfoot is part of the mechanical axis. Malalignment will lead to joint damage. Symptomatic malalignment must be corrected. Be more aggressive. It's not just the ankle that needs care. Whatever below the ankle also needs to be corrected. Use phaco and MRIs to guide treatment and evaluate outcome. Thank you very much.
Okay, thank you, Kim Wai, and a wonderful talk. I'm sure that our participant has lots of questions, especially the subtalar stabilization. So I think we may put all the questions at the end of after the lectures. Without further delay, may I invite Professor Lee to give us a talk on ankle replacement. Yeah, Professor Lee, please.
Good evening, everybody. Thank you very much for your kind introduction. Can you hear me? It's okay?
Yes, yes.
Okay. Today, I'm going to talk about the ankle replacement in hindfoot deformity, my algorithm. As you know, in the end stage ankle arthritis, we can do the arthrodesis or the total ankle arthroplasty. As you know, in the arthrodesis, we can overcome the deformity, but in total ankle arthroplasty, through the total ankle arthroplasty, we can correct the minimal deformity. So we have the question about that kind of things, how to correct the major angular deformity by total ankle arthroplasty. As you know, in the Asian population, there are a lot of very severe varus ankle osteoarthritis. So total ankle arthroplasty in deformed ankle, even in the case of the major deformity, total ankle arthroplasty is possible. As you can see, in severe incongruent varus ankle, you can we can do the total ankle arthroplasty through the correction. And also in the valgus ankle arthritis, we can do total ankle arthroplasty at the same time the hindfoot correction. So total ankle arthroplasty in deformed ankle, the most important thing is that minimizing the residual deformity. That is the key for the successful outcome. So in order to correct the concomitant hindfoot deformity, we can do the ankle joint correction by the total ankle arthroplasty, but it has certain extent of the correction. And the other way is the subtalar joint correction through the subtalar fusion or the calcaneal osteotomy. And so we can divide the deformity into varus deformity and the valgus deformity. In the varus deformity, we can classify into incongruent varus and the congruent varus. In valgus deformity, we can classify into valgus with fibula shortening or the some malunion of the around the ankle. And the other one is the valgus with the posterior tibial tendon dysfunction. In varus ankle deformity, we published this paper at over 10 years ago. We got the best paper presentation award in the 2010 AOFAS advanced training course, and also we published this paper too. In the varus ankle, we can correct through the medial release. We can make some talus into the neutral position, and after that, in the congruent varus, we will do the regular tibial cut. But in congruent varus, we need the high tibial cut. After insertion of the implant, still opening of the lateral, and then lateral application procedure. Through that kind of way, we can obtain the symmetric ligament balancing. We can see some more detail. In congruent varus, as you can see, through the medial release, we can correct the varus talus talar position. And after that, insertion, regular tibial cut and insertion of the implant, still opening of the lateral, and then we can do the peroneus transfer or the rostrum operation. This is my way, sliding release of the deltoid ligament, like through the straight osteotome, we will release the medial tightness like that. And also, I prefer the peroneus longus transfer to the to brevis, and then through that kind of way, we can make some symmetric ligament balancing. This is the case, as you can see, very severe, nearly 28 degree of the varus ankle deformity. That is the gross photo. And heel alignment view over the 30-degree varus. And we can do total ankle arthroplasty and the medial release of the deltoid ligament and the medial calcaneal, lateral calcaneal closing wedge osteotomy, something like that. And 14 years follow-up, you can see the very good clinical outcome. In the congruent varus ankle is a different story. As you can see through the medial release, we can correct the talus into the neutral position, but we need a high tibial cutting. And still opening, the symmetric ligament balancing procedure is the same. That is the congruent varus ankle. As you can see, 20-degree congruent varus ankle. And through the medial release, we can do the total ankle arthroplasty like that. And the eventual follow-up, it was 9 years. You can see a very good clinical outcome. And after insertion of the implant, we need to check out the hind foot alignment. Still show the heel varus and then go to the calcaneal valgization osteotomy. After calcaneal osteotomy, we need to check out the first lay position. The first lay plantar flexed and then go to first metatarsal dorsiflexion osteotomy. That is the point is that simultaneous correction in the ankle and the hind foot is very important in the deformed ankle. In the valgus ankle deformity, as I told you, we can classify into valgus with the fibula shortening. This patient, as you can see, valgus ankle arthritis with fibula shortening. So we did the total ankle arthroplasty at the same time fibula lengthening. Eventually, 12-year follow-up, he still showed a very good clinical outcome. And the other type of the valgus ankle is the posterior tibial tendon, stage 4. Stage 4, as you can see, very severe valgus with the ankle arthritis. So in this kind of case, we did the total ankle arthroplasty. At the same time, gastrocnemius release and the plexus digitorum longus transfer, and also the medial displacement calcaneal osteotomy was done. Totally, we published this paper at the 2012. There is the valgus ankle, there is the my algorithm like that. So you can find out in paper in the Foot and Ankle International. And also we published this paper in the other paper. And also we did some research with the Dr. Hinterman group at Swiss, total ankle displacement in association with hind foot fusion. Over 60 cases, we compared the total ankle arthroplasty versus total ankle arthroplasty with the subtalar or the triple arthrodesis. Comparable outcome between groups, BAS score, AOFAS score, and the complications. So hind foot fusion should be performed when it is indicated. That is the case, as you can see, end stage ankle arthritis and also severe talonavicular joint arthritis. So at the same time, we did the total ankle arthroplasty with the talonavicular fusion with the same incision. Eventually, 11-year follow-up, as you can see, he showed a very good clinical outcome. Another one is the osteoarthritis with the subtalar joint arthritis. In this kind of case, you can see the heel varus was the 20 degrees. So we did the total ankle arthroplasty at the same time, subtalar fusion. So 7-year follow-up, as you can see, that is very good clinical outcome. And also another case, ankle arthritis with some subtalar joint and the talonavicular joint and the calcaneal cuboid joint arthritis. So at first, we did the triple arthrodesis first, and after that, we performed the total ankle arthroplasty. So 12-year follow-up, As you can see, there are some kind of osteolysis in the anterior portion of the distal tibia, but the clinical outcome was excellent. At this year, at last August, we published this paper, long-term clinical outcome and the implant survivorship, 151 total ankle arthroplasty using the Integra processes, a minimum 10-year follow-up. It was published at the Journal of Bone and Joint Surgery, American volume. In this paper, our total ankle arthroplasty clinical outcome was favorable, and also 93.5% of the survival rate at 11 years. So no significant correlation between pre-op deformity and the failure or the revision. So we can perform the total ankle arthroplasty at the same time subtalar correction, kind of correction. In conclusion, varus deformity can be corrected by sliding medial release without residual instability or AVN of talus. Lateral plication without medial release cannot overcome medial tightness. Valgus deformity can be managed by fibular lengthening or tendon transfer with calcaneal osteotomy. And also the hindfoot fusion should be performed when indicated. Thank you very much for your kind attention.
Okay. Thank you, Professor Lee. So without further delay, may I invite our first speaker, Rajesh Simon from India, to talk about the ankle fusion, the hindfoot fusion.
Yeah.
Thank you.
So am I visible? Am I visible?
Yes, I can hear you. Very good.
Yeah. Yeah. So we've been hearing about beautiful talks about the ankle replacement and the bio-alignment. But then there is a role for the fusion, and that is what my topic is today, when and where. I bring greetings from India. So hindfoot fusion is always thought as a salvage procedure. It is, for me, I think many times the amount of deformities which we see in India, I see this as the limb-saving and a life-changing procedure from misery to smile. You think about hindfoot fusions, there are so many indications which we've seen now, which could be not done without fusion, but with total ankle replacement or malalignment or supramalleolar osteotomy. But then there are this end-stage arthritis wherein you might have no other goal other than the fusion, like in the cavus or residual clubfoot, coalitions, or some of those neurological diseases, which leads to you don't have much of an option but to do a hindfoot fusion. The aim, as we always have, is pain relief, deformity correction, restoring the alignment, and improved physical functions. The isolated, you have the different components in hindfoot fusion, and isolated versus double versus triple, and then you now also have the tibio-talocalcaneal fusion or the pan-talar fusion. Everyone has its own place. If you look at various papers, you find the isolated fusions have got its more importance. For example, here, when you have a talocalcaneal fusion in the medial facet, you can get away with an isolated subtalar fusion, and the patient does good. This paper of Andrea says that the talonavicular arthrodesis versus the triple arthrodesis is mechanically favorable when you have an isolated arthrodesis done, and the ankle peak pressure is reduced with the isolated talonavicular arthrodesis compared to the triple arthrodesis. So in all, they say that the isolated, we find the place and get an isolated done if possible. The classical paper which actually led to the thinking of triple to double was this particular paper from Astian, where he said that the arthrodesis of the talonavicular, as we all know, reduces the movement of the other two joints significantly. And when you do both talonavicular and subtalar joint, almost completely eliminates this CC joint movements. So this was the paper which allowed people to think from triple to double arthrodesis. So when you look at triple versus double arthrodesis, which will work function, if you look at the results, this is a systematic review came out just recently in 2022. And they say that the conclusion is double arthrodesis is as effective or alternative to triple arthrodesis. If you, another study, which again is a cohort prospective study of 23 patients, saying that this double arthrodesis is an equally reliable surgical option for an AAFT3 stage. And this one was one more, again, a recent where 2 cohort studies were found, and the authors concluded that double arthrodesis is good enough if the calcaneocuboid joint is not affected. So the double arthrodesis today, you have an advantage of preserving the CC joint, decreased operative time, lesser surgical cost, fewer sites of potential complications, and preserves the lateral column length. With the advent of medial double, you have the decreased operative time, excellent deformity corrections, and provide good rates of fusions. At the same time, allows the CCJ or reorientation of the lateral column. So the results, double versus triple, I think both have its place. Double fares better in most of the places, but triple has its role also. Here is one case. Classically, we see the stage 3 AAFT, see the patient coming with severe pain, and you get away with a post-corrective double arthrodesis, and all the arches, everything comes into picture, and patient finds it well. When you go beyond the double or the triple classical fusion, the TTC fusion has come in a big way now. And now we use TTC for a lot of functions, including today that we have the fragility fractures of ankle, Charcot arthropathy, wherein we do the TTC fusion very commonly. Here is one patient wherein this is, you can see the gross instability of the right ankle. Patient had some kind of fracture initially, treated with plaster. On removal of the plaster, patient was found, the ankle was found to be grossly unstable. And when we took the X-ray here, when it was referred to us, this is how the X-ray was: a complete Charcot chain conversion of post-traumatic fracture, bimalleolus fracture. And since it was neuropathic, patient did not have pain, and we could salvage the limb with a simple talonavicular, the TTC fusion. Post-traumatic instability is also another way of problem. So here is a 47-year-old lady who already had a cavus foot with twisting injury and has been sitting on it with severe pain for a few years. Now the deformity persisted. Now these are the things which I always think, supramalleolar osteotomy, will it help? But then this was grossly osteoarthritic in both talonavicular and subtalar joint, the ankle and the subtalar joint, and we did it with the correction of the TTC and the cavus correction, and the patient goes on to walk. Fragility fracture is something now we've come into doing the TTC fusion. This was a 51-year-old patient with an CKD, diabetes, all the comorbidities. And the surgeon goes on to fix this trimalleolar fracture beautifully into the lateral malleolus, but the medial malleolus is not so good fixed, and the posterior malleolus is left alone. And like any other normal fracture, he starts weight bearing on 6 weeks. And this is what is the end result. At 6 weeks, the whole thing breaks up, and then without realizing that this is a neuropathic conversion of neuropathic foot. And so we salvage them with a TTC, and patient goes on to walk reasonably well. So salvage with the hindfoot fusion always helps in such type of patients. Inflammatory arthritis, which is rheumatoid, young lady would have preferred a total ankle with a subtalar arthrodesis in a little more older, but 36-year-old female. This, I think, was a better off was to do a TTC rather than doing a total ankle in our scenario, wherein you want to have more robust type of life ahead. Pantalar arthrodesis is now getting into more. We in India are having the diabetic capital of the world, so we're getting lots and lots of Charcot patients, and the salvage with super reconstruct formula needs the Pantalar. So here you can see a 48-year-old lady with a complete hindfoot and midfoot Charcot, now having gross instability, difficulty in walking because of instability, not because of the pain. And this is how we do an extended Pantalar super construct, and the patient limps back to walking. Of course, never walking normally, but reasonably good with a compared to an amputation. And lastly, we do have such type of cases that comes in India. This is a case of clubfoot and super added with polio when she was a child. So basically at 43 years old, she comes with an history that she has never walked with her feet on a plantigrade feet. And this is how she comes at 43 years with severe pain. There is no neuropathic foot here. The sensations are normal. And this is how the x-rays would look like. A completely folded, underdeveloped foot in a different plane. And if you look at the 3D reconstruct, you can find that the calcaneum itself is hardly formed. And when I saw this calcaneum, I was aghast whether there is any calcaneum. So we got further 2D, and we found that there was some kind of shell in the calcaneum. But then this is what the scene was, and the patient was absolutely not willing for a below knee amputation, which I did offer to this patient. So we did a plan of TA lengthening, TTC arthrodesis with closing wedge osteotomy. And this is how we went with an OLS approach after the TA lengthening. And we went on to get the hindfoot into alignment, and then midfoot closing wedge osteotomy. But by the time I finished this, the bones started crackling because these bones were never put into pressure all these years. And so I had to put a X-fix. I stopped in between, put an X-fix, and then put her on a BK slab for some time. And then this is how it looks. The X-ray was not looking very great here, but then this is how at 10 months the leg looks like. And a lady who's never put a plantigrade feet is quite happy walking with her feet on the floor. So these are the indications for hindfoot fusion. I don't think we can do such type of cases without hindfoot fusion anytime. So hindfoot arthrodesis is a limb salvage and a life-changing surgery many a times for me. Definitely you have to have a meticulous preparation of all the joints, especially when you're looking at Charcot foot. When you're taking at too many joints, you have to be meticulously preparing everything. Soft tissue management is of paramount importance. There is definitely a better understanding with biomechanics and trying to save the joint, but arthrodesis has its day. Thank you very much.
Oh, thank you very much. Yeah, thank you, Josh. Thank you very much. So next section is case discussion. And may I invite Andrew to present some interesting cases and let our panelists for further discuss.
Thanks, Prof. Let me just share my screen again. How's that? I guess everyone's got that, haven't they?
Yep.
Yep, very good. Okay, thank you very much for the invitation. A little bit in awe of all the excellent speakers before me. Hello out there to Kinwai. Nice to see you again.
Yes.
So the first case is a 59-year-old, well, but in typical Australian fashion, an overweight woman. Interesting injury to the ankle about 3 years ago. We don't know which way. And she's been suffering for 3 years now with pain and increasing valgus deformity. Now it's mostly medial-sided pain with some subfibular impingement. Here's the x-ray that we see. Now, if you think back to, this is an ankle x-ray, but then we've got some image of the foot there to suggest that this is not just an ankle alignment issue, it's a subtalar issue, has been clearly identified much earlier on. You look at the lateral and we see that Meary's line is emerging below the margin of the metatarsal shaft. Obviously the heel spur is no big issue. Looking close at the ankle joint, there's not a lot of impingement. There's not a lot of osteochondral lesion. And, I guess the question is, and while I don't have a clinical image for you, I think the professors clearly know what this is. I was just wondering whether we have any input from the 100 people listening to us. Probably not. Okay. So it was identified under ultrasound at the time because she was not keen to get in the MRI, degenerate dysfunctional tibialis posterior tendon. Now, this obviously wasn't just the only issue. Having failed all her non-operative management, no doubt in Australia, we have $1,000 orthotics that people like to buy. We suggested that surgery at this point might be indicated. And we did an all Australian, tender Achilles or gastroc lengthening, take your pick, but we do a stria recession, an FDL transfer from the second FDL, a medial heel shift, which is usually done percutaneously now, unless the bird isn't ordered, a deltoid and spring ligament plication. And we do use a sinus tarsi spacer. We've used the Hypercure as per Kinwai, sometimes not available. In this case, you'll see what was done. Right. As far as the weight-bearing mortise view is concerned, you'll notice that there is an anchor in the medial malleolus, and that was to imbricate the deltoid ligament. But otherwise, the mortise itself is congruent with equal space around the joint. And Mary's line has been reestablished, and you can see how it compares pre and post on the right side of the image. Okay, so the next case, this guy is young. He's had a previous fibular fracture, as you can see. Now this, thinking back to whether it's a congruent or incongruent ankle, it's effectively congruent.
That is the valgus ankle arthritis.
Correct,
so
correct. And it is different. I'll show you the lines that we drew there. So it's a significant valgus to it. And the management of options for this person is that, they work in the mines. I think a total ankle replacement is not a great idea for these people. We want to maximize their range of motion because they get down low in the mining. I think the concept of arthroscopy for this, while it's reasonable and some papers suggest that it can be used as an option, is not an option for this patient. Would anyone say otherwise?
Yeah, maybe we can invite Kinwai or Professor Lee. Yeah,
Oh.
I see Professor Lee has some opinion.
For this
How old
case,
is he? How old?
Oh, sorry, he's 35.
35.
Yeah, quite young.
So in the kind of case, total ankle replacement is not indicated.
Yes, yes. So we strike that one off the list, but there it is.
Mhm.
Kim Wei.
Supramal, yeah.
After
Kim
much
Wei?
discussion, would you agree with that, or would you do it differently?
I think osteotomy would be an appropriate choice for this patient, like so, because
It's good.
most congruent ankles, if they're not rotated within the mortise and they sit nicely within the mortise, they tend to do quite well with when the mechanical axis is restored, even though it looks terrible on the x-ray. There is very little joint space left, but they last for a long time as long as the mechanical axis is corrected, even though it
Yes.
looks pretty arthritic. So I think for
Even though,
35-year-old,
yes,
this
but
is
he's too
very
young
reasonable.
to. Would anyone consider fusing it? I mean,
No, the osteotomy,
No.
supramalleolar osteotomy with the fibula osteotomy is that
Yes.
indicated. It's good, very
Okay.
good. But
Thank you.
the problem is the ankle. So after
Yes.
the supramalleolar osteotomy, and then wait and see, still have the pain on the ankle, and then we can try some distraction arthroplasty or something like that. Because the
Indeed.
patient is too young.
Yes, we have a significant number of these who work in the mines, and they have to go back to work, and it's a heavy load on the joint. So yeah, totally agree. Eventually, though, he might be looking maybe in his 40s. Hopefully, he's moved on to a different occupation.
But how did he respond to this surgery? I suspect that he might be quite pleased.
Indeed, indeed, he was pleased, Kim Wai, because they wear steel cap boots when they go down. So his alignment was, his total range of motion of the ankle wasn't the biggest issue. So he was very happy.
Do you think impingement at certain level would be there, which can improve slightly with the scopy? Many a times when you do a supramal.
Whenever I do a supramalleolar osteotomy, I always do an arthrotomy and remove any impingement. But since I'm doing such a big bony operation proximally, I don't usually do it under arthroscopy. I will just make a small little arthrotomy wherever the major impingement is, and I'll just remove it open. But yes, I agree that a lot of the pain from a malaligned joint is due to the point and edge loading and impingement, especially in the ankle. So that's why I said this patient, once you get a good alignment, I believe he's quite pleased. His pain should be quite well alleviated.
Indeed, indeed, and hopefully when he's in his 60s, he'll come back and we can have a long-lasting.
For a long time as well.
Yes, yes.
I don't think he needs anything in his 40s,
Definitely not. It'll be good to see the back of him for a while.
Yes.
I'll just move on to the next one. So this was an interesting one, which actually Dr. Gridget gave me, and some of you might have seen this before. 49-year-old, 2 years post ankle fracture out in the middle of nowhere. That was, and when we say nowhere in Australia, it is nowhere. And treated non-operatively by the emergency physician, and sadly enough, displaced with a large anterior defect. It's a tough one because he's subluxed, and he's lost height, lost length, and his alignment is well, hard to tell, but it's significant varus. I'll just quickly go through. So what are the options there? And in a person that that's 49,
Diabetic? Is the patient diabetic?
No, that's the thing. They're not. They're not. The query is it a neuropathic joint? Well, it wasn't. It was just poor management, and
it's not painful.
Even,
I mean,
oh, it's non-functional. He's 49. He has to go to work, and we have significant social security problems here. We like to send them back to work. This person's been out for the last 2 or 3 years, and again, thinking about everything we've talked about before with the speakers that have gone before, but adding the possibility in a person who is sick of his ankle, he hates it, he doesn't want it. The usual of, the ones that are dangerous, dying, infected, or just plain useless. In this case, it's just plain useless. But I think the last option would definitely be the last option to consider if we haven't ruled out all the ones above. Professor, do you think, I just feel it's definitely not one for a replacement. Yeah.
In this
So,
kind of case, we can do some very complex total ankle arthroplasty, as you can. Please go back to the sagittal angle X-ray, please. We can make some lower tibial cut, and then the remnant cutted posterior portion of the bone can be grafted into the anterior portion of the distal tibia, and also make a correction of the medial malleus into the position, and then we can do some total ankle arthroplasty like that. I did this kind of case, 2 or 3 cases with the neutral cut of the distal tibia, and the remnant of the posterior tibial bone was grafted into the anterior position, and then we can do the total ankle arthroplasty. But it is a very difficult case.
very difficult case. Would you consider using augments? When I was with Beat Hinterman, and that's why I asked you, he did use a lot of augments, which are 3D printed augments.
Mm-hmm. But it is not available in Korea, so we cannot do some 3D printed augmentation. But anyway, we can try to make some kind of operation, but we need the imagination.
Yes, and hopefully a 3D image, which I'm not giving you. We haven't really stepped into that realm yet here down under, so we did something simple. We used something that Sanjurjan and Grujic wrote up, and universal distractor using a fresh frozen femoral head allograft. We have a lot of access to that here with the Australian Bone Bank. The femoral head allograft was soaked in PDGRF, and we use an articulated tensioning device, of course, to get everything in, get our length and position. That looked reasonable. I mean, my biggest worry with any graft that's not vascularized is that it gets resorbed, but this one worked out pretty well. No, that was a 3 incision. Oh, well, the one at the back's percutaneous, but 2 incisions front and medial. And at 6 months, it looks to have survived, but be interesting to see how we go beyond. Do you think this burns our bridges as far as if this fails, where would we go? Anyone?
I think we still have a choice.
Sorry?
I think we still have a choice of the salvage with a nail.
Yes.
I would probably do what we do for the Charcot foot is take the fibula and make a bamboo hut type of around that talus. The head of femur, which probably would progress, we will probably cut and put a strut graft around the nail, and it eventually usually fills it up. That's how it is salvaged a couple of our Charcot feet.
That's brilliant.
I think we can still salvage even if the head collapses.
Does anyone have access to a plastic surgeon who could give you a vascularized fibula?
No.
No. We do have one, but he's hard to get.
we have plastic surgeons around, but I think the tibia talar fusion with the bone graft, exactly as you have done so, would be my choice, my first choice. And if this fails, I would salvage it with a nail.
Absolutely. Thank you.
But having said that, fibula graft, it is very unlikely that the vascular fibula graft would survive there when you're putting inside.
Right.
So
Right,
it's
that-
more of
that-
a theoretical advantage rather than a practical thing.
Indeed, indeed, and it's no doubt drawing from other parts of the body with these vascularized fibular grafts.
Alternatively, you
so-
could, alternatively,
Sorry?
with talking about the graph, alternatively, if you don't mind doing a two-stage procedure, you can do a mascale procedure. And
Yes,
fill up that gap with a blob of cement and wait for 2 to 3 months. You go back in again and you get that nice membrane and you graft the membrane and they tend to do quite well.
and would
Yeah.
you'd stabilize that with a nail?
Initially, in order not to contaminate the
Or
area, I
frame.
would put an external fixator
Yes,
if I do a
yes,
first
and
stage
circular maybe.
mascale here. Or well, one of those unilateral with the
Okay.
HA pins. They tend to hold
Yes.
quite well for a couple of months.
Absolutely. And we've got plenty of options there, and I think we're starting to see some of these cases sort of slowly creeping in from the rural areas here. All right, so we've got a 60-year-old farmer, inverted commas, ankle injury 3 years ago with a sprain, never recovered, now worse. Here's some x-rays.
Mhm.
Nothing really jumps at you. I mean, there's a anterior neck osteophyte, loss of joint space, he's invarus. Usual, the same options, sorry.
There
Subtalar
is the
joint.
typical. There is the typical incongruent varus ankle osteoarthritis.
Yes,
So it can be indicated for the total ankle arthroplasty.
so tick for that. And all the others, again, they exist, but we've got
I would
options.
do an osteotomy.
Absolutely, absolutely. But this is what he says, because he's a farmer and they go back and they have to, either harvest the fields or, round up their sheep, whatever they do, they hate surgery. Very often what we find here, they do two things which we don't agree with. One is PRP and the other is cortisone until the cows come home, which ruins our surgery. But anyway, but then again, he comes back a year later after trying all that other stuff and his pain is worse.
Wow.
Wow.
Yeah. So, as I've alluded to, the GPs in the rural areas love needles. And rural here can be the distance of flying from Singapore to Delhi within the same country. So,
Is there any kind of infection in there?
impaction of the
Ankle.
Infection.
infection. Oh yes, sorry, no, ruled out infection. I'll just show you that. So ESR and CRP were normal. We were worried that, oh, well, it could be that he's got something neuropathic going on, but no, normal. But is it a Charcot or is it just simple AVN? Well,
You should be ruled out that tuberculosis.
yes,
Yes.
yes, and that's very relevant
Yes.
in Asia. We're quite lucky in Australia. We haven't had any tuberculosis now, I think, since the end of the Second World War. But we have Mycobacterium bovis, which occurs in cows. Fortunately, very, very rare, but definitely worth considering. So, what to do? So,
I
did
think
some
first we
EUAs
have
to
to
have a
rule
look
out.
at the. Yeah, sorry.
I think I will always want to rule out any kind of infection before
Yes.
jumping into conclusion.
Absolutely. So, say he's aspirated. Well, first of all, he's got an ESR and CRP that's within normal range. Secondly, I usually aspirate. Yes, totally agree. And in this case, the surgeon of the time, you'll see it on the X-ray, did not find anything cultured.
Mhm. But you need
so-
to do some tissue
Biopsy.
Tissue biopsy.
tissue biopsy.
Yes,
There.
yes. And you can do that arthroscopically or just a simple small open arthrotomy. And I
Mhm.
think that's very reasonable. But hypothetically, let's say that everything was ruled out. And I thought I'd show this because we were talking about the nail. And this is a time when Les was using, well, he went from valgus nails to straight nails back again. And this is what was done with a fibular osteotomy to obtain a plantar-grade foot and correct the coronal alignment with a small amount of corticocancellous graft obtained from the iliac crest. And this is in a patient as completely agreed that's not infected and has no contraindications to metalwork.
Good salvage.
Yeah,
Yeah,
survived.
it is very lucky. There
Did you
is no
see this one?
infection.
Did you see that one?
Mhm.
Yeah.
It doesn't
yeah,
matter
and,
usually.
must yes. Unfortunately, one of the problems with that length of nail. But keeping him non-weight bearing anyway during the period with a brace non-weight bearing to allow the fusion to take and the fracture healed.
Mhm. Usually that kind of tibial fracture doesn't matter.
Yes, yes. He was protected though, because being a farmer, they take a lot of liberties and they don't listen. Next one's an 80-year-old male, and he's got hemochromatosis, and he presented with what looks like concurrent, and it's hard to tell if varus or valgus, but his clinical images. Sorry.
Neutral.
Neutral. Yes,
neutral position of the osteoarthritis.
Yeah. Yes, except that his toes are a little bit externally rotated. And it was the subtalar joint looks to be also affected by degenerative change. I thought it was valgus, but I'm sure it's neutral, except that the toes are a little into valgus there.
Nice.
So I shouldn't have said that, but anyway, the option taken was to do this. And you'll notice, I'm sure you've all had experience with this prosthesis, the TM prosthesis. And what we found was it was able we were able to, and again, look at those feet. They're not as splayed as previously. Through a transfibular approach, we're able to obtain a nice congruent ankle, stable, and making use of the congruency of the prosthesis, give him good range of motion. Except that he was a very naughty boy, and we had a few wound healing issues on the fibular side. So using, in this case, and I'm sure you're aware with the surgical procedure using for the TM ankle, it uses a frame, an external fixator frame to stabilize the ankle with a transcalcaneal pin to correct varus and valgus. And that makes it just that little bit easier to stabilize the ankle when making the cuts, which are done obviously transfibular with a burr. Okay, here's another one. No deformity, but disabling arthritis.
And
Andrew,
maybe this may be the last case because
okay, I'll just show you that. I'm going to fly now. So again, just for Professor, notice what happened to the integra, and what do we do? That was our salvage.
Yeah, in the kind of collapsing that some talus and the tibia, there are a lot of bone loss. So in that kind of case, is the only salvage way is the TTC fusion.
Yes, and we used
with some
the pre-op and have a look at what
caused it.
Could have contributed.
Yes,
the pre-op.
We I don't have those, but he was a varus hindfoot. So one of the things I think we drew from the talk on the TAA was that we need to correct the alignment, and I think that's a big part of a big part of total ankles.
Yeah,
All right, that one is one of
yes.
Les's. We'll leave that. I just wanted to ask you about this one. So yeah, male cyclist, 75. You can see bilateral varus arthritis, failed everything else. And I'll show you what we did. And I was just curious to see whether anyone has had a replacement on one side and a TTC, because he has subtalar arthritis as well, not just ankle arthritis and varus. Is that a reasonable thing, or do you find that your patients not like it? Are we cut off, are we? Hello?
Hello?
Okay.
I don't
Any
think-
forwards, or you're happy with
I
that?
don't think it's contraindicated. I think if the indication for a TCC is there and the indication for ankle replacement is there, I think you choose the best indication
Absolutely.
for that foot, rather than match it up with things that is going on elsewhere.
Totally.
But
Which
the
side
more
was
interesting-
done first?
So what I didn't show you was the left side was originally fused. The ankle was fused with one of those anterior plates that looks like a finger. And it went on to non-union. And ironically, when he came to the rooms, it was the subtalar joint that was more sensitive and sore. But that left us with a non-union of the ankle with a arthritic tender subtalar joint on that side. So it wasn't a difficult takedown. We ended up doing that. But on the opposite side, he had greater varus deformity. And I think the option taken there was we were concerned that the prosthesis wouldn't be able to last the distance. He's a bit of a cyclist. He also bowls. So that's the only ankle he needed to bend was his left ankle. So we did the left and then did the right later.
I'd like to ask you which side you did the operation first, left side or the right side? Left side first, you did?
Yes.
Okay.
And he was happy with it. Again, you know, with subtalar fusions, I'm sure you've all had experience that post-operative period is essential and important to ensure the fusion takes.
And how many years are you after surgery now?
This guy is now 6 years.
So I'm curious to know which side is he happier with?
It's no different. He's happy with both.
Mhm.
But it's just the way he uses the way he makes use of his feet. So bowling, he comes forward on the right side, so he's got to dorsiflex the left. And with cycling, well, he just doesn't use clip-ons. He uses just puts his feet onto the pedal.
As you know, if you do the both side fusion, he cannot do the bowling or any kind of sports activity due to some stiffness.
Yes. And it'd be interesting to see when I get him to 10 years. It's sort of a single case study. I will update you. Thank you.
Thank you, Andrew.
Thank you.
Thank you
very much.
Yeah, and this is almost the end of our
get out of that.
webinar. Yeah, maybe I have recap what we have discussed. So this was, I would say, is a very fruitful, and Kim Wei give us a wonderful talk on the biomechanics of Hindfoot and the importance of a realignment procedure. And also Professor Lee give us an indication of a total ankle replacement, tips and tricks of some surgical techniques as sometimes complication. And Dr. Simon already also give us a Hindfoot fusion tips and force, and also the double versus the triple fusion. And through the case discussion, we learn about the Savage procedure for failed total ankle replacement. So this is the, I think, how to say, all of our webinar has room for improvement. And this QR code mainly for participant. And please fill up, and we want to know the feedback as well as the after the feedback, you have certificates of attendance. And this is our next webinar. And we'll talk about the elbow pathologies on the 8th of October. So remember, okay, our big event is coming. Okay, just 2 weeks after. 2 weeks after, this is our SICOT Congress at in KL. So welcome all of you to join. So this is the end of our webinar, and once again, thanks of our all speakers, Kim Wai, Dr. Simon, Andrews, and Professor Lee. Thank you very much, and enjoy your weekends.
Thank you.
Thank you.
Bye.
Thank you, everyone.
Bye,
Thank you.
bye,
All the best,
bye.
everyone.
Bye.
See you in
Bye,
KL.
Andrew. Bye-bye.
Bye-bye. See you
Bye.
in
See
PM.
you. Bye, bye.
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 Excellent case, Andrew.